Thank you very much, Claire. So what I'm going to talk about is the impact of ethnicity on the COVID-19 in kidney dialysis patients. And this is on behalf of the entire Pan London COVID-19 audit group. You've already heard from Ben, and he talked a lot about the risk factors for admission and risk factor for acquiring COVID in this dialysis population. I'm going to talk about the outcome, which is case fatality in these patients, which is quite high. Can I have the next slide, please? So while the next slide is coming up, there were, as you saw from Dr. Kaplan, there were 1,009 patients altogether. And the data were collected on quite a lot of variables. We collected data on 25 different variables. I think slides are coming up any minute. And it was between the beginning of March and 31st of May 2020. And these were from all the hemodialysis patients in the 7 London units. What was interesting, while the slides are coming up, is that we had a very large proportion of non-Caucasians in the population. It was 70%, 793 patients altogether were non-Caucasians compared to Caucasians. So this was an opportunity to look at the case fatality and the dynamics of the inpatient population. By dynamics, I mean the ratio of death to discharge in these patients during the hospital admission. The next slide. So as I was mentioning, there were quite a lot of non-Caucasian. As you can see, 793 patients were non-Caucasians compared to 293. So this was an opportunity to look at this population for the impact of ethnicity. And just to remind you that only 54% of the patients were admitted in hospital. So when I talk about death and discharge, remember the death, majority of the deaths happened as inpatients. The next slide, please. So what were the population characteristics? So the mean age of the population was 62 with a standard deviation, 65 with a standard deviation of 14. There were 61% males. There was a lot of hypertensives, as we all know, but there were quite a lot of diabetics. 52% of these patients were diabetics, with a proportion with lung disease, 17%. Quite a lot of patients with ischemic heart disease, which is nearly 40%. And the fistula was the dialysis access in 40%, the rest were online. So you can see this is quite a high risk population by these risk factors that are shown on this slide. What was interesting was we actually collected data on frailty. And you can see that there was a significant portion of the patients who were not self-caring. So World Health Organization frailty score 3 to 4, which is 6, 7, and beyond in the usual frailty score that we use in our hospitals. Next slide, please. So this is the death and discharge of the inpatients. You can see that if you look at the graph, that most of the deaths, which is on the red line, happened very early on. And within the first 20 days, most of the deaths had actually happened, and 85% of the deaths happened within 14 days. And discharges also happened in a few patients rather quickly. And then the discharges were kind of delayed. In a sense, there was a group of patients who stayed in hospital for a long period of time. And we wanted to see whether this was same in the different ethnic groups. And as you can see in the slide, the case fatality in this first surge of COVID-19 positive patients in London was 24%. Next slide, please. So what were the risk factors for death? And this is a very complicated slide, but what I've done is on the left-hand side, I've summarized our findings. So age and frailty were very, very strongly associated with mortality. And you can see not only the univariable association, but also in multivariable associations, as the substandard hazard ratio were higher for age and frailty. Ischemic heart disease was another important factor contributing towards death. And Of course, patients who were admitted, i.e., as you can see from the diagram of the hospital on the left-hand side, had a higher proportion of deaths. And patients on the laboratory parameters who had high CRP was associated on univariate model, but on multivariate model, what was significant was a neutrophil lymphocyte ratio. But what is important in this slide was that ethnicity, which is at the top, you can see that had no effect. We looked at white versus non-whites, i.e. Caucasian versus non-Caucasians, and there was no significant difference in the case fatality ratio in both univariate and multivariate models, indicating that maybe these patients were so sick that it didn't matter what ethnicity they were. The mortality was very similar. Next slide, please. So here, a little bit detailed analysis on the cumulative incidence of death and discharge. So death on your right-hand side in the figure at the top, and discharge on your left-hand side, and the different bars indicate the different ethnic populations, and we have whites, blacks, Asians, and others. And you can see there was no difference between the four groups as far as the cumulative incidence of death and cumulative incidence of discharge were concerned. And you can see in the table below, as I mentioned before, there was quite a high non-Caucasian population with 29% Asians and 31% Black. But you can see in the next two columns, it shows the death and the discharge ratios between these populations were very similar. Next slide, please. So when we did the statistics on it, we found that compared to whites, the non-Caucasians had no significant difference in cumulative incidence of death or discharge. Next slide, please. We also looked at the London Renal Registry data and compared with the COVID-19 positive data from these 1,009 patients. And what we found was, now, let me remind you, this is just, this is not adjusted for other risk factors, but you can see that the patients who had COVID-19 were slightly older, 64 versus 63, and a slightly higher proportion of males. And here you can see that the infection proportions were higher in the non-Caucasian population compared to the Caucasian population. So indicating that there might be a possibility that these ethnic groups had a higher proportion of higher risk of having the infection. But I don't have the other risk factors that Ben had taken into account in his study. And of course, diabetes is a risk factor here. Next slide, please. So in summary, there is not enough evidence to suggest that death was associated with gender or ethnicity, whereas age, frailty, ischemic heart disease, hospital admission, and neutrophil lymphocyte ratio were. Whereas when you look at the entire population, males and non-Caucasians were slightly higher proportion in the patients who had COVID positivity, like the more elderly and more diabetics. So my conclusion is in the next slide, which is non-Caucasians are perhaps more likely to get infected with SARS-CoV-2 amongst the hemodialysis patients in London, but there is not enough evidence to suggest that death was associated with being non-Caucasian in the COVID-19 positive hemodialysis patients. And part of the data is already published, which was shown to you by Ben, which is on the website below. I'll stop there. Thank you very much for listening.
Thank you very much, Deb. It's very interesting. In some ways, we can take some reassurance from it, but it maybe poses more questions than answers. And maybe it just highlights that if we do find ourselves in a situation again, maybe we can sort of focus on some specific questions around that.